Hey y'all, it's Dr. G, back for another episode of Discussions with Dr. G. And I hope you're ready for some real talk because today we are diving into a world that too many healthcare folks wish they could avoid. Substance use disorders. It's not just about the stereotypes or what you see on those after-school specials. We're talking actual science. That messy intersection where brain chemistry, genetics, and plain bad luck all conspire against our clients. So, quick crash course, right? Addiction. It's this ugly three-part cycle. First, the binge or intoxication phase, where the fun starts. Then withdrawal with all those charming negative feels. And then you land in this preoccupation or anticipation stage, obsessing about the next hit. Rinse, repeat, and suddenly, life feels like one endless hamster wheel, only with less cardio and way more consequences. Everybody's always on about dopamine, and for good reason. Dopamine is like the Vegas slot machine for your brain. All flashing lights and rewards. But honestly, it's not just dopamine. Glutamate's in there too, egging everything on. And good old GABA tries playing peacekeeper by calming things down. But when someone's using substances chronically, that balance goes totally haywire. Think of a cat chasing its own tail. Except, less cute and a lot more dangerous. Genetics. Don't get me started. Up to 70%, yeah, you heard me, 70% of the risk for substance use disorders is genetically linked. Let's take a step back for a moment. There are 5 opioid receptors available. Mu receptors, which are responsible for analgesia and euphoria. Delta and nociceptin receptors, which are primarily associated with analgesia and anxiolysis, which is a reduction in anxiety. Kappa receptors, which are associated with dysphoria, or a state of unease or dissatisfaction, and sedation. And finally, zeta receptors, which, let's simplify their role. They are primarily responsible for developmental processes and tissue renewal specific to cell growth. Now, you have that tidbit of knowledge, we can move forward again. So what about nicotine and alcohol, you ask? Nicotine and alcohol both stimulate the release of endorphins, which then activate the mu receptors to produce a sense of pleasure and reward, which enhance the release of dopamine and contribute to the reinforcement craving and dependence cycle. You see, with opioids, nicotine, and alcohol abuse, it's all about the mu receptor. In this large percentage of the population, opioids attach more easily to them, causing immense feelings of euphoria. And the fallout from that: tolerance, withdrawal, cravings you can't think your way out of, and a higher chance of medical chaos, like heart problems, liver problems, cancer, depression, suicide, you name it. Think of it this way. Your brain is literally wired to panic if you don't get the substance. It's a survival level drive with substance use disorders. Now let's shift gears to the action part. What the heck do we do about it? Medications. These aren't magic pills, but they are vital tools in the fight. Let's start with opioid use disorder. All right, so we've got opioid antagonists like naltrexone, naloxone, buprenorphine naloxone, that's Suboxone for the brand loyal, and of course, methadone. Naltrexone is your long-term blockade. Picture it as a bouncer kicking opioids out of the club, blocking those mu opioid receptors, not letting the euphoria or reward stuff even get started. But here's where it gets sticky. You cannot be actively using opioids before you start it. Otherwise, boom, precipitated withdrawal. Ugly stuff. You want to make sure your patient's opioid-free for at least 7 to 10 days before you even think about naltrexone. The safest bets? Check a urine drug screen. Maybe do a clinical opiate withdrawal scale or COWS scale if you're fancy, and monitor those liver labs. Hepatotoxicity isn't just a scary word, it is a real risk. And don't forget the mood piece. depression and suicidality can creep up. Now, naloxone. That's the action hero, swooping in for an emergency reversal of opioid-induced respiratory depression. Family members, even friends, need to know how to use it. And yes, I once joked in a naloxone auto-injector training, if only my cats could administer them. They're always first on the scene when I drop anything on the floor. But seriously, teach administration, monitor airway and respirations, and remember, naloxone is short-lived. You might have to redose. So you're going to keep an eye out for acute withdrawal. You can get everything from agitation to pulmonary edema. Fun, right? Moving on to buprenorphine naloxone, or Bupanol, or Suboxone. It does some mu agonist dance, helping smooth out withdrawal, but with a ceiling effect, so you don't worry as much about severe respiratory depression. Naloxone's tossed in as a deterrent for misuse, and not the cute kind. This combo is great for outpatient and home use, but get ready to watch out for dangerous combos. If you toss benzos or alcohol into the mix, you've got a box warning and a threat of respiratory depression. Monitor for withdrawal, and little known fact, this stuff can really wreck your dental health. Dental caries galore. Don't skip on the oral hygiene talk, okay? Now on to methadone, the OG, full mu agonist, full power, so awesome for controlling withdrawal and cravings, but you need a super regulated clinic setup. Downside, besides all the drama with the DEA, it drags a risk of QT prolongation. Yeah, those torsades, ECGs you rarely see in school, but absolutely never want to see in real life. So check ECGs, monitor those sleepy, slowed respirations, and hound your patients to show up for those clinic doses. It's teamwork, people. Onward to nicotine use disorder. Weirdly, the most stubborn habit for a lot of folks. Let's break down your med options. Bupropion is a fascinating one. It blocks dopamine and norepinephrine reuptake, which drops cravings. But wow, if you have a history of eating disorders or you're in withdrawal from alcohol or benzos, this med is a no-fly zone. Why? Seizure risk. And as always, suicidality hovers in the risk profile. So mood checks are not optional. Nicotine replacement therapy. Patches, gums, lozenges, sprays, all the flavors, right? Nicotine in a slow, controlled drip instead of an all-out hit. Main things to watch: hypertension, tachycardia, skin or mucosal irritation. Oh, and let's talk about technique. Site rotation for patches. Bite and park for the gum, not like actual chewing gum. And patients never get this right on the first time, trust me. Now, varenicline, partial agonist. So it plugs into those nicotinic receptors, blocks the reward buzz, so smoking's like super boring now. Downsides. We're talking vivid dreams, psychiatric effects, suicidality, Steven Johnson's, which is rare but memorable. One patient told me their dreams with varenicline were so wild, they called us at 2 a.m. Nurses jumped in to normalize, counsel, and kept them on track for quitting. And you've got to start this med at least a week before quit day. Renal checks, skin assessments, and mental health screens become their new routine. Alcohol use disorders. All right, because we know it's everywhere in acute care and the med list can look like you're playing bartender, not nurse. Let's start with disulfiram, the ultimate deterrent, your instant regret in a pill. It blocks aldehyde dehydrogenase, which means if you drink, you are in for a flushing, pounding heartbeat, wicked nausea, and vomiting. All the stuff no one wants on a Saturday night. Never give this to someone already intoxicated. That just turns up the danger dial. And watch out for hidden alcohol and stuff like mouthwash and cough syrup. which, let's be honest, most patients won't read until it's too late. Benzodiazepines are your first-line magic for withdrawal. Think lorazepam and chlordiazepoxide. These save brains from seizures and keep delirium tremens at bay. Dose using the Clinical Institute Withdrawal Assessment Alcohol Scale Revised, or the CIWA-AR protocol for short. You should conduct constant neuro and vital checks and keep seizure precautions ready because you never know when you need them. And don't even think about mixing benzos with opioids or more alcohol. That is a bad, bad combo. Now, for keeping folks dry, a camprosate gets the spotlight. It plays with GABA and glutamate, so cravings stay manageable. But heads up, renal impairment means this is a no-go, so you've got to check on those kidneys. Suicidal thinking is possible, so don't take any "I'm fine" at face value. Please dig a little deeper. Last but not least, let's not forget about vitamins and electrolytes. If you ever see thiamine, folate, or magnesium all written together, you're probably trying to prevent Wernicke-Korsakoff syndrome, or WKS, which is identified by confusion, disorientation, memory loss, and difficulty learning, sometimes double vision, nystagmus, unsteadiness, wide bases when they're standing up, muscle weakness, hallucinations, and confabulation. By the way, that's making up memories of things that didn't actually happen. Other signs of thiamine deficiency include anemia and cardiac arrhythmias. Trust me, you do not want to meet WKS in your career, so check those electrolytes, monitor your IV sites, and always do a neuro check because symptoms can sneak up fast. All right, let's talk real world nursing practice and clinical judgment because this is where stuff truly hits the fan. Withdrawal versus medication side effects. Sometimes it feels like a guessing game. Say your patient's a little sweaty and tachycardic. Are they withdrawing or having a weird med reaction? Cue recognition is crucial here. You need your assessment cap on tight and maybe some strong coffee. Think stepwise. Administer safely. Then set up ahead of time seizure pads, suctions ready, fall precautions are in place, especially with anything that sedates. If there's ever a whiff of suicidality, don't wait. Escalate and get help. Your role doesn't stop at giving meds. You're on the front lines of education too. Teach patients and families about med adherence. Look out for anything they're picking up over the counter, including herbal teas, which can actually mess with some of these meds. Get ahead of relapse triggers before they become an issue and evaluate constantly. Are they abstinent? Are their cravings down? Is safety still intact? If not, it's time for plan B, or maybe plan C, or maybe even plan D. So, if you're new to nursing or even just new to behavioral health, let's rapid fire some pearls you'll want on mental speed dial. With naltrexone, remember that opioid-free window or you'll have a really bad day. And liver checks every time. Naloxone, it works fast, but it wears off fast, so stay vigilant. Suboxone is safer than methadone for most, outpatient friendly, and yep, I'll say it again, watch that dental health. Methadone is super effective in the right setting, but real talk, I've seen more than a few torsade scares. That ECG isn't just paperwork, I promise. For nicotine, bupropion is great unless there's a seizure risk. Nicotine replacement therapy is as much about technique as pharmacology, and the big red flag there, always monitor mental health with varenicline. Alcohol, a quick mnemonic. Disulfiram is for deterrence. Don't accidentally mix it. Benzodiazepines are for withdrawal. A camprosate for ongoing or maintaining abstinence. Medication errors in inpatient psych are a fact of life. Dose timing, missed contraindications or box warnings that read like horror novels. I remember the first time I taught new grads about buprenorphine box warning. I swear the box was scarier than my pharmacology final. The point? Set systems so that those warnings don't sneak up on you. Use your judgment and get comfy asking questions, even if you think they're dumb. 10 out of 10 times. That's what keeps patients safe. All right, that's a lot for one episode. If you stuck with me, congratulations. You officially now know more about managing substance use disorders with meds than my cats do. Next time, we'll dig into some more pharmacology. So stay curious, take care of yourselves and your patients.